Okay, good afternoon, everybody. Everybody mute your computers and phones.
Mute it. Hello?
Please turn off your computer and your phone.
I thought about it. We were talking, so I'll call you as soon as I finish. Okay.
Please turn off your computers and your phones. Okay, I'm talking today on hypopituitarism and growth hormone deficiency. Pituitary hormones, what's the big deal? Pituitary disorders are common, but experts in treating them are not. Small changes in replacement may make a big improvement in symptoms. Many endocrinologists do not understand how to properly replace patients with hypopituitarism and do not understand or don't believe in monitoring hormone levels. We simply see the need to do more. The hormone axes include the adrenal axis, the pituitary cells that make these hormones are called corticotrophs. The hypothalamus makes CRH, which goes to the pituitary to make ACTH, which goes to the adrenals to make cortisol. The thyroid axis, the pituitary cells are called the thyrotropes. The hypothalamic hormone is called TRH. It goes to the pituitary to make TSH, and that causes the thyroid to make T4 and T3. The gonadotropes are the cells in the pituitary that regulate your estrogen and testosterone. GnRH, LH, GnRH is made by the hypothalamus. LH and FSH are made by the pituitary. Everybody please mute your phones and your computers. It goes to the gonads to make testosterone in men and estrogen in females. The growth hormone axis is made by the somatotrope cells in the pituitary. The hypothalamus makes GHRH, it goes to the pituitary to make growth hormone, and it goes to the liver to make IGF-1. The posterior pituitary, which I'm going to be talking about today, and because of interest from some of our participants, makes AVP and Oxytocin. And again, please mute your phones. Sheehan syndrome.
I guess you have to deal with them.
Please mute your phones and your computers.
Is my computer muted?
No. Hypophysitis, pituitary infiltration, empty sella, malnutrition and critical illness, and head trauma. Stalk and hypothalamic causes of hypopituitarism include tumors called craniopharyngiomas, CNS tumors, surgery, radiation, head trauma and accidents, infiltrating diseases such as sarcoidosis, histiocytosis X and hemochromatosis, infection, drugs such as steroids, dopamine analogs, and somatostatin analogs. This is a very important slide. There is a specific order of hormone deficiencies. The first hormone that's affected if the pituitary is damaged is growth hormone. The next set of hormones are the gonadotropes, FSH and LH, followed by TSH, followed by ACTH. Prolactin is rarely affected, and the posterior pituitary hormones are rarely affected, but it may be that we don't look for them carefully enough. The paper that we published in 2008, please mute your phones and your computers. The paper we published in 2008 took 38 patients with non-secreting microadenomas. These are small pituitary tumors. The mean size was 4.2 millimeters, and we took patients with normal serum IGF-1 levels. 19% of the patients, or half of them, were found to be growth hormone deficient. They had a higher body mass index than those that passed the growth hormone releasing hormone arginine test and healthy controls. 19 patients had at least one other pituitary hormone defect, most of the testosterone. Some of them had thyroid problems. We concluded that a substantial number of patients with non-secreting pituitary microadenomas were growth hormone deficient despite normal serum IGF-1 levels and had at least one other pituitary hormone defect, suggesting that non-secreting microadenomas may not be clinically harmless. Microadenomas and hypopituitarism. We then concluded that patients with low IGF-1 and microadenomas are even more likely to be growth hormone deficient. Many endocrinologists test for hypopituitarism only if a patient has had prior surgery or radiation to their pituitary. I think this is an incorrect approach. My approach is to measure pituitary hormones in patients with signs and symptoms of hypopituitarism, and if the lab tests show hypopituitarism, then I get a pituitary MRI. We'll start talking about growth hormone deficiency. Patients with hypopituitarism have increased mortality that's suggested but not proven to be due to growth hormone deficiency. Growth hormone deficiency in adults results in decreased bone formation, increased fat mass, specifically central obesity, decreased muscle mass, lipid abnormalities, increased thickness of blood vessels, increased inflammatory markers, impaired quality of life, increased number of sick days, and impaired exercise tolerance. Most importantly, most of these symptoms are corrected by treatment. So this growth hormone deficiency is an extremely important diagnosis to make in patients because their quality of life is very poor and it can be helped by treatment. What I do is I screen with an IGF-1. If it's in the top 75% of normal age and sex, approximately greater than 150, growth hormone deficiency is less likely. If the patient has an empty cella, history of head trauma, headaches and low blood pressure after delivery, which is called Sheehan syndrome, history of pituitary surgery or radiation or pituitary tumor, such as a micro or macroadenoma, the growth hormone deficiency is more likely. If the IGF-1 is less than 75, growth hormone deficient is pretty likely. However, even in spite of the measuring the IGF-1, you need to do stimulation tests. In general, glucagon stimulation test is the preferred test, and we do that in Los Angeles here. And the cutoffs is unclear and going down. Most of the insurance companies, we'll talk about in a second, want you to be very severely growth hormone deficient. A lot of them, some of the societies recommend a cutoff of either 5 or 3. Some of the patients with good signs and symptoms of it, I would diagnose them growth hormone deficient if they're less than 8, but in general, more people are moving to a 5 or a 3 cutoff. You can use an insulin tolerance test. In general, the cutoff for that is 5. And for the most part, I use a glucagon stimulation test. The only advantage, really, of the insulin tolerance test is that it also measures cortisol and can be used for adrenal insufficiency workup, but I think there's other tests better for adrenal insufficiency that I talked about in our last webinar. Therefore, most of the time, we do glucagon stimulation tests. There's a concept that growth hormone deficiency should be severe to be treated. I don't agree with that. In general, in medicine, we often treat patients with quote-unquote mild hormone deficiencies, such as growth hormone. And I think one of the problems is the stimulation tests are non-physiological, but they're required and they're considered the gold standard. And you want to see what's happening on the day-to-day with what the IGF-1 is and other variables and signs and symptoms. But in general, we still rely very heavily on the growth hormone stimulation test. So in general, you have a person with hypopituitarism, a pretty low IGF-1, and normal stimulation testing, such as a glucagon stimulation test. I think the question is, what do you do in those cases? I often use a supplement called TDT-tropin. It used to be called trans-D-tropin. The company that made them stopped making it, but there's several companies that make products similar to that. It's made by amino acids, and it stimulates the hypothalamus to secrete more growth hormone-releasing hormone, and it's available at compounding pharmacies such as the College Pharmacy, or you can get it directly from tddtropinplus.com. When you treat patients with adult, please mute your phones. Thank you. When you treat patients with adult growth hormone deficiency, the dose is much lower than that of children. If adjusted for body weight, it would be about 10% of the body weight of a child. You don't need to adjust for body weight. Women, especially on oral estrogens, need higher doses than men. In general, I start at 0.4 milligrams of growth hormone for women and 0.2 milligrams for men. And for the most part, I give it at night. The final dose varies widely and cannot be predicted. Some people only need that 0.4. Some people have to go down on it occasionally. Some people have to go up to as high as 1.6 milligrams. I titrate upward with IGF-1 measurements monthly. I aim for an IGF-1 in the upper third of the normal range, approximately 200 to 300 nanograms per mil. There's usually not much improvement in symptoms until this range is achieved. And the main side effect of too much growth hormone is joints, especially hand swelling and pain. So I always ask for that as a sign or a symptom of too much growth hormone, and if that is the case, we cut down on the dose of growth hormone. So I want to talk about this concept, and this article is on my first page of my website of goodhormonehealth.com. Should you treat mild growth hormone deficiency versus cortisol deficiency? Which one should you treat? There was a somewhat controversial article that was published in Journal of Clinical Endocrinology and Metabolism in June 2013 that suggested that idiopathic, which means without a clear-cut cause, of growth hormone deficiency does not exist. I don't terribly agree with that, and I think there's plenty of people that have growth hormone deficiency, and at least you can't find the cause. The article suggested that growth hormone deficiency should only be treated if it's severe and if the patient has other pituitary hormone deficiencies. And in fact, many insurance companies require that the patient has at least 2 or 3 other hormone deficiencies before treatment. And to me, this makes no sense because, as I said earlier, growth hormone deficiency is the first deficiency to occur. So a patient can have mild damage to the pituitary and be growth hormone deficient, but not have other hormonal defects. So the question is, why is it recommended mild growth hormone deficiency not be treated? On the other hand, almost everybody treats mild cortisol deficiency. And in general, in medicine, we look at the benefits and risk of treatment. The treatment for cortisol deficiency is giving a medicine called hydrocortisone or Cortef. And certainly if hydrocortisone is needed, it should be given. But in many borderline cases, it is unclear. Please mute your phones. Certainly if hydrocortisone is needed, it should be given, but in many borderline cases, it is unclear whether hydrocortisone needs to be given. Giving exogenous cortisol shuts down the adrenal glands from making its own cortisol. Therefore, once you start cortisol, it may be very hard to stop it. Additionally, excess cortisol, and it can be very hard to give the right amount of cortisol, leads to weight gain, diabetes, infections, and osteoporosis or thin bones. Many endocrinologists erroneously feel that the patient can die suddenly from cortisol deficiency, and therefore it's better to give everybody that has a borderline cosentropin test cortisol. This is based on old literature and really occurred only in patients with severe cortisol deficiency. More recent literature suggests that patients with mild cortisol deficiency do not die suddenly and do not necessarily need to be treated with hydrocortisone, and the benefits of treating with exogenous hydrocortisone most likely outweigh the risk unless the cortisol deficiency is severe. And in general, hormone replacement should be guided with symptoms. Patients with low cortisol have nauseousness, vomiting, diarrhea, abdominal pain, joint pains, and weight loss. Many patients have failed their costantropin test, or cortisol stimulation test, and are told they have mild cortisol deficiency, don't have these symptoms, and are still given cortisol. And in fact, most patients with hypopituitarism have more symptoms of excess cortisol, such as weight gain, than low cortisol deficiency. In contrast, patients with growth hormone deficiency do have weight gain, they have trouble sleeping, they have psychological and psychiatric problems, including depression, mood swings, and irritability. Their quality of life and functionality is much lower. All these symptoms are improved with growth hormone deficiency. Growth hormone replacement has very little side effects. The main side effects are joint pain and swelling or edema. Some patients on growth hormone replacement can get worsening glucose control, and that is reported in the literature. But in general, my experience is most patients feel so much better on the growth hormone replacement. They exercise better, more, they feel better, and their blood sugar improves and doesn't get worse. And I haven't published this yet. I'm trying to do a study on this, but in general, I found that patients with mild growth hormone deficiency do just as well on growth hormone replacement as those with severe. And if they have a stimulation test, a glucagon stimulation test, their growth hormone peak between 3 and 8. They benefit from growth hormone replacement just as well as those that have a stimulation test of less than 5. Less than 3. I suspect the real reason why mild growth hormone deficiency is not treated while mild cortisol deficiency is treated has to do with cost and insurance. Growth hormone replacement is quite expensive and can cost over $1,000 a month, while cortisol replacement is quite inexpensive. Because of the cost of growth hormone replacement, most people need their insurances to pay for it, and insurance companies are getting more and more reluctant to cover growth hormone replacement, possibly because it is so expensive. However, I'm really interested in improving the patient's quality of life, especially those with hypopituitarism, so I try to fight to have the patients with mild growth hormone deficiency covered by their insurances, so those patients could benefit from growth hormone replacement. Not always we succeed, but most of the time with appeals and trying to fight the growth hormone companies, insurance companies, we are able to get the patients on growth hormone. Next topic I'm going to talk about is diabetes insipidus. This is due to a deficiency in the hormone ADH, or vasopressin, it's also called. This is a posterior pituitary hormone. The main symptoms are excessive urination and thirst. Mild cases are probably common and worthy of treatment, and I think this is underdiagnosed. Chronic excess urination, called polyuria, can lead to bladder and kidney problems, and the first question I ask is how many times the patient has to wake up at night. If it's more than one, I am concerned about this as a patient who has hypopituitarism. I screen by having the patient collect the urine for 24 hours and measure the volume. Greater than 3 liters indicates that diabetes insipidus is likely, and I confirm with a 12-hour fast, no water, and collect an 8 a.m. serum and urine osmolality. In diabetes insipidus, there's high serum osmolality, usually greater than 300, low urine osmolality, less than 500, and low AVP levels of less than 1. So I usually measure those 3 things, and you don't need to do what used to be called a formal water deprivation test, but this test usually works quite well. We replace them with DDAVP. There's both pills and nasal puffs. The pills in general work the best. The nasal puffs are also effective, but if you have a stuffy nose, sometimes they're not absorbed that well. In general, I have my patients take most of the dose at night to prevent waking up at night, and you should have a period of breakthrough urination. Treatment is quite benign as long as you don't over-replace somebody. You can drive down their sodium if you give them, and make them swollen if you give them too much. But in general, most patients do quite well on a pill at night. And we have a lot of interest in this next topic on oxytocin. Oxytocin is made by the posterior pituitary, similar to AVP. And it's really the only prominent pituitary hormone that's not tested or replaced. Oxytocin has been suggested to have a role in bonding, intimacy, orgasm, GI issues, trust, generosity, pain, and energy. A 24-hour urine oxytocin is commercially available at Meridian Valley Labs, but I don't yet have any information on how reliable is this assay. You can replace oxytocin. The compounding pharmacy, Bellevue Compounding Pharmacy, supplies it as both sublingual tablets or nasal spray. And I'm trying to get a questionnaire for hypopituitary patients to complete before and after oxytocin administration. And we'll see if the patient improves on oxytocin. And I'd like to measure 24-hour urine oxytocin before and after oxytocin administration. And you can contact this if you are an established patient, and we can possibly give you this in the near future. If you're not an established patient, you can set up an appointment with me, and then we can evaluate you for this as well as your other pituitary hormones. So what's the problem? Most patients are on too much cortisol, not enough thyroid medication, not enough growth hormone, no growth hormone, not enough testosterone. This often leads to weight gain and depression and other poor quality of life. So get your doses adjusted and get on the proper medicine. And I think my next chat will be on estrogen and testosterone. My website is goodhormonehealth.com. You can email us at mail@goodhormonehealth.com. And let me unmute everybody, and we can open up to questions. You know, don't have any background noise when we do this, so we just hear the questioner.
Dr. Friedman?
Yeah, yes. Let me unmute everybody, then we'll take some questions. But everybody, please try not to have background noise. You can maybe take questions via the chat also. Let me start with that once I unmute everybody. Somebody's having a lot of background noise. All right. Okay. So let's start with a couple questions. Anybody have a question?
I have a question.
Okay.
This is Janet, and I'm going to be doing the oxytocin. Hi there. I'm going to be doing the oxytocin testing that you mentioned, and I'm currently taking an antibiotic, and I'm wondering if that will interfere.
So I don't think antibiotics should affect this.
Okay. Okay, thanks.
Okay. So if anybody wants to send a question either by the chat or by the talking, and hopefully there won't be too much noise, go ahead with your questions.
I have a question.
Okay.
This is Adina Blumenfeld.
Hi, Adina. How are you?
Hi. Good. How are you?
Okay.
So my question is, in the matter of testosterone and estrogen and progesterone, how?
I don't know.
Somebody's having a lot of noise here. Bonnie, are you having a lot of noise?
Yes.
Okay.
So I know that the estrogen and progesterone, and probably also the testosterone, is supposed to be like it's supposed to be like a yin-yang situation that it's supposed to be, I forgot the exact word. So how do you know that if someone's taking, for example, 0.75 milligram of estrogen, and it's a woman, doesn't the testosterone have to be like half or a quarter of that in order for it to be like a yin-yang situation?
No, I think in general the estrogen and testosterone are basically adjusted separately. And many women, for example, with polycystic ovarian syndrome, you could have a high testosterone and a relatively normal estrogen. In hypopituitarism, it sort of depends on which cells are affected. and how your adrenals and your ovaries are. But in general, I adjust the testosterone and the estrogen based on signs and symptoms, as well as laboratory testing. And some people don't need testosterone and do need estrogen, and some people the other way around. In terms of progesterone, I would say there's a little bit more of a yin and yang effect with progesterone, because when you put people on estrogen, if you don't put somebody on progesterone, they have uterine buildup. So you do want to balance it. Most people that go on estrogen do need progesterone, but there are some cases that you can go on estrogen and not progesterone. In some cases, you go on progesterone but not estrogen.
Maybe some of that.
Okay.
Dr. Friedman.
Yes.
Hey, my wife, Cheryl Fryer, is one of your patients, and wanted to know from the presentation, how long after a patient starts growth hormone do they really start feeling the positive benefits, typically?
So the question is, how long after being on growth hormone do you start feeling better? And I would say it's two things. One is looking at the IGF-1. So I like the IGF-1 to be the upper half of the range. If you're not there, you're probably not going to get much better. If you are there, then I would say, usually in about a month, you should stop feeling better. And the question that somebody asked is about the range is different for both men and women, and it's dependent on age. And therefore, if you want to get a measured in a lab, like Esoteric does, that corrects it for the age and the gender. And you want to adjust the values for what somebody of the right age and gender should be.
So basically, once they get on the appropriate dose for their age and gender.
I'm sorry, go ahead. Yeah, go ahead, Richard.
Oh, I'm sorry. So basically, once the patient's dose is adjusted based on sex and age, you can look at approximately 1 month before they can start really feeling the effects or the efficacy.
Yeah, I think as long as their levels are good, then I would say they should start feeling better in about a month.
Thank you so much.
Okay, sure.
I have a question. My name is Steve.
Yes, go ahead.
No, go ahead, finish what you were saying first.
So somebody asked the question about if a serum test for growth hormone came back normal, is it okay to rule it out at that point? So the serum test, I'm not sure what the person is referring to. The growth hormone itself, you can't measure because growth hormone itself is pulsatile. So you don't usually measure growth hormone to diagnose growth hormone deficiency. However, again, the gold standard is to do a growth hormone stimulation test. And I would say in general, if you pass that test, you are unlikely to be growth hormone deficient. If you fail the test, you are. So that's basically what we're doing as the main way to determine growth hormone deficiency.
Bill Joe does it.
Next question was, how accurate is the arginine stimulation test? It's not very accurate at all. So the arginine stimulation test used to be done with growth hormone releasing hormone, and together it was quite accurate. Growth hormone releasing hormone hasn't been available for about 5 years, at least maybe, and the arginine test alone really is not accurate. The glucagon stimulation test is much more accurate.
Question, right?
Next question.
I have a question.
Okay.
I'm a patient of yours also.
Mm-hmm.
And basically, I had my growth hormone I'm 36 years old, and my IGF-1 was 99. Very symptomatic. Have a pituitary tumor. Am now being treated for the low cortisol. But with IGF-1 at 99, I did a glucagon stim locally.
Okay.
They did it wrong. They only did the 2 hours. But my concern is, I know you had ordered for me to go to the 4-hour test.
Right.
But I had a very bad reaction. Like lethargy, I couldn't walk, I couldn't speak right. And I don't feel that it would be safe to go to 4 hours. So basically what scares me is that I feel I could be deficient. I stimmed to a 6.6. But having the glucagon injection made me very, very ill. Couldn't walk, couldn't speak right.
Go to sleep.
Right. So 6.6 is a borderline response. Most people would consider that you passed it. So if you're 6.6 up to 2 hours, it's the highest value that you look at. And therefore, if you did it to 4 hours, it would certainly at least be 6.6 or higher. So I would say it's unlikely you have growth hormone deficiency with this value, and I would look into those other products I talked about, the TDG tropin. At least let's put it this way: it's unlikely your insurance will cover you with a 6.6. So I would look into using those other products like TDG tropin.
Okay, now speaking of insurance, being that I'm symptomatic and with the tumor, and now I'm on cortisol, and I don't want to be covering up something that could be healthier for me, be it maybe growth hormone.
Right.
I would like to take on that battle with insurance, being that there's other insufficiencies and a tumor there.
Right.
If you feel that trying it and seeing if my IGF-1 can go up and my symptoms can go up could possibly get me out of bed and improve my quality of life.
Yeah, I think it's possible. You know, the insurance companies may say it should have been a 4-hour test and should say 6.6 is borderline, but we can try to push for it to you. Send us your results.
Awesome. I'll take them on. Thanks, Dr. Friedman.
Okay.
I have a question. Can I ask?
Okay. Sure.
Yeah. My name's Steve. I had a Cushing surgery in June, and my endocrinologist is working on with me some replacements. I'm on hydrocortisol, levothyroxine, and DDAVP. We're gonna work on getting testosterone after my next post-op once I get an approval from the neurosurgeon. But lately, I've been waking up with just soreness in the bottom of my feet, and it's mostly in the morning. It's throughout the day if I walk around on them and put a lot of stress on them. But when I wake up in the morning, and I didn't have this at all pre-surgery.
What is your cortisol level?
My cortisol level right now, I'm on 50 of hydro and weaning down.
And what you know?
Maybe, yeah.
You have a serum cortisol level after withholding?
I'm not. Fasting in the morning, my cortisol level was 0.
Oh, okay. You know, I would get down on your cortisol. It sounds too much. It could be growth hormone deficiency. It could be testosterone. In general, you know, you probably are going to need to, if you have diabetes insipidus, it means did they take out a large portion of your pituitary?
I have 25 left. My endocrinologist said though that I don't have everything except for my growth hormone. She said is working fine, but I'm kind of skeptical on that.
Yeah, I'm very skeptical about that. Set up a come out and see me. I think we can assess it, but it sounds like you know, most people have the growth hormone as the first one that's affected.
Yeah, I'm gonna have her do the IGF-1. If I mention that to her, she'll probably understand what that means.
Well, start with an IGF-1, and then you'll need a stimulation test.
The
glucagon. Right.
Glucagon so I'll ask her for those two things.
Right.
Okay, thank you.
Okay, so the next question from Alexandra is, how often should IGF-1 be checked after it's determined to be in the appropriate range? And why doesn't everybody mute their own phone until they're ready to ask the question and then unmute your own phone? Because we're still getting a lot of background noise. So I would say once the IGF-1 is in the range and the patient's feeling good, I would say every 3 to 6 months might be a good time to check it. And, you know, sometimes it's very dependent on other medicines. For example, testosterone can raise your IGF-1 up. So you start going on medicine like testosterone. Oral estrogens lower your IGF-1. So I really try to avoid patients taking oral estrogens or birth control pills or on growth hormone. So anytime you change your medicines, you probably do need to be checked again. Adina has the question about salt sugar cravings when lowering cortisol indicates that the dose of cortisol is too low. It's a possibility. I think you have to look at the whole symptoms and the lab values on that. But it might be a possibility that shows too little cortisol. Adrenal insufficiency can give you low cortisol levels, and you compensate by sugar craving.
Do you have a sugar craving?
No. I'll craving, but that's sugar craving.
Okay, Alexandra also asked about 15 years hypothyroidism treated for growth hormone deficiency for 2 years. unrelenting fatigue and weight gain. She should try to come see me. I agree with that. Other things missing might be testosterone, estrogen, thyroid, although, maybe her thyroid's not optimized. Some people we talked about in the prior hypothyroidism talk may need T4 plus T3. A percentage of patients don't convert their T4 to T3 well and may need T4 and T3 together. So those are some of the possibilities why Alexandra is having fatigue and weight gain. It's thyroid, testosterone, estrogen, and we're going to start the study on the oxytocin. Maybe that's going to be a key thing.
Oh, I have a question about the T4, T3. So it's Steve again. My levels, I was told, for the T4 and T3 are both good, but I want to be on the best treatment that I can be.
Right.
Should I give a natural desiccant? Is that what it's called? Natural oxygen, a chance for a few months, just to kind of see how I feel? Or if my levels, if my endocrinologist says my levels are, good.
So I think it's worth trying desiccated thyroid. Some people do better on it. I'll talk about this maybe. I'll come back to hypothyroidism in a couple webinars in the future. But there was an article that just was published in Journal of Clinical Endocrinology and Metabolism, the top journal in the field, comparing desiccated thyroid to T4. And surprisingly, it showed that they were pretty similar. The patients liked the desiccated thyroid better, and they used only a once-a-day desiccated thyroid dose, which is not optimal. They didn't add T4. Most people need some T4 with it. And in spite of that, and the TSH was too high in it, in spite of that, the patients did at least as well, if not better, than the T4. So I think this is a very important paper, again, suggesting that some people do need desiccated thyroid instead of T4, T3.
Maybe it also suggests that people need more T3.
Right. So some people, need a higher dose of T3 usually to keep their levels in the normal range. So each person has to be individualized to optimize their levels.
I have another question about thyroid. What do you go by? Do you go by the labs or by the patient's symptoms?
Yes. I go by both. In general, I like to keep the T4 and T3, free T4 and free T3 in the normal range, preferably in the top half of the range. I don't like to have it above the range, but within that normal range, then I would adjust it based on the signs and symptoms, primarily symptoms. So some patients would do better on a higher, free T4 and free T3, the upper half of real near the top of the range. Other patients, they start getting palpitations and tremors and sweating, and they do better toward the middle or lower part of the range. So it's a combination of labs and symptoms.
What do you do if there is a patient that their T4 and T3 is on the upper level, but they still have symptoms of hypothyroidism?
I think we have to, we evaluate that individually. Okay. Sometimes it takes a while for the levels to adjust, and we can try other combinations. Sometimes instead of Armour, I would use a T4, T3 mixture. Sometimes there's other, there's WP thyroid. There's different types of desiccated thyroids.
Okay, very interesting.
The next question about genetic testing for siblings with growth hormone deficiency and hypopituitarism. I don't know if any. There are rare genetic diseases of growth hormone deficiency, especially one where the receptors don't work. There's a condition called Laron's dwarfism, where the patient's growth hormone receptor doesn't work, and that is genetic. But for the average person that has hypopituitarism, most of the time it's either due to a surgery, radiation, or a tumor, and it's not genetic. So somebody has a tumor, there are some genetic tests for familial tumors. And there's a colleague of mine in England who took a couple of my patients and tested them for a couple of genes she was looking at, and they didn't come up with anything, but I was sort of cited on the paper. I wasn't a co-author.
Hi there, this is Katerina.
Hi.
I'm sending a bit more of a history in a chat, but to be more brief, I had a resection a year and a half ago. delayed diagnosis of growth hormone deficiency through an ITT test. And I started on growth hormone about 8 months ago. It seemed to work very slowly and very slightly in the beginning, and then I was put on core test more recently as I started to get very symptomatic with nausea and vomiting. The ITT did show low ACTH and cortisol when I did it. Before the growth hormone started. I've just been on the core test for about 2.5, 3 weeks now, and I'm trying to get used to it. I seem to get a lot of dizziness, and I have a crash period in the afternoon around the time I'm supposed to be taking the dose. I'm wondering if I should be splitting my dose differently or taking it sooner, perhaps at 8 in the morning to take my first dose because of the insomnia. But I do take my first 10 milligram dose first thing in the morning, and then usually around 5, 6 hours later I take 5 milligrams. Should I be doing it differently to avoid the dizziness and the feeling?
Yeah, so first of all, there's two axes in your adrenals. One is cortisol, one's aldosterone. In general, hypopituitarism is known to affect the cortisol axis, but occasionally it can affect the aldosterone axis. So it sounds to me like you have low aldosterone. The symptoms of low aldosterone would be dizziness, lightheadedness, palpitations, low blood pressure, salt craving. Do you have any of those symptoms?
All of them. I have all of them.
Right. So I would start by taking more salt. You can have your doctor check a renin and aldosterone level, and you can go on 4NF. You can also take grapefruit or grapefruit juice or licorice root. You can get licorice root from Amazon.
I was actually taking it before.
Right. So all those things will help increase the cortisol binding to the aldosterone receptor in the kidneys and raise your blood pressure. So I think I would try to optimize that. In terms of insomnia, I did a study when I was at the NIH about 20 years ago showing that patients with Addison's disease, they don't sleep well, they don't go into REM sleep if they don't get a little cortisol at night. So we usually used to think that cortisol would make people more awake at night. Actually, it's a low dose, like 2.5 milligrams or 1.25 milligrams at bedtime, can help you sleep. So that might also be something to add in terms of your insomnia. Whoa.
I have a question regarding...
Wait a second. One more. Let me answer one more thing I was going to say about that. Can't remember what I was going to say.
Saying the nighttime dose.
Right, the nighttime dose may help. And, you know, in general, you want to be on as little cortisol as you can because long-term it has detrimental effects. Oh, also, yeah, you said about taking it before you wake up. That's often helpful. Set your alarm an hour before you wake up, put your cortisol by your bedside, take some, and then go back to sleep for that last hour. And then it'll be in your system when you wake up.
I've done that, and I wake up in such a fog after a couple of hours. I've tried that method, too. It doesn't seem to help me. Right. I do have better energy earlier in the day, but it's just I really crash in the afternoon. So I should maybe split that 5 milligram into 2.5 and 2.5?
Yeah, and maybe take a little bit
before bed.
Before you go to bed.
I have a question about the cortisol at night.
Sure.
Yeah, so before my surgery, I was getting chronic migraines all the time, like 3 times a week, 4 times a week, really bad. And after the surgery, even though the neurosurgeon told me it wouldn't do anything, I really don't get these anymore, which is good, but it's bittersweet. But I read the things about taking the cortisol at night, and the night that I did that, I woke up like in the middle of the night with a chronic migraine, or with a migraine, like really bad. Does that make sense for certain people? Have you seen something like that
I haven't
before?
seen that. No. I think it should help your migraines, and you would think that you'd have low cortisol at night, and it should help a little bit. But each person's different. If it doesn't work, don't do it.
I'm not gonna do it, but I just want to know if you'd seen.
I haven't really seen that. No.
I don't know if that makes me feel better or worse. Okay.
Right. Cushing's patients have a lot of migraines, so that's high cortisol. So in theory, maybe high cortisol can give people more migraines. I usually see it more with low cortisol, but you know, just make sure your cortisol replacement is optimal. Alexandra has a question about growth hormone is considered idiopathic. Is there a reason to look for a cause? I think, you definitely need to get a pituitary MRI and make sure you don't have a microadenoma. You could have Sheehan's, you can have a small pituitary. So I'd say anybody that's been diagnosed with growth hormone deficiency does need a pituitary MRI. Mary asks, can pituitary microadenomas resolve spontaneously? I would also say yes to that. I think there's two things. One is it could be overread by the radiologist, that somebody could have a small thing seen on the pituitary that a radiologist says is a tumor, and then it's not really there. The next time they do it, a different radiologist reads it, and it's not there. You can also have mini strokes to your pituitary tumors that they can infarct and the tumor can go away. Okay, Sarah asked, she's had TSH low for many years, replaced it with natriuretic and tyrosine. She has really bad hyperthyroid and spells of neck swelling, found the mass where the lingual thyroid typically is found. Could it be releasing without TSH from the pituitary? I have an iron uptake test this week. And yes, you could have, so her question is, she has a low TSH, is the low TSH from her pituitary not working, or from overtreatment from natriuretic and tyrosine, or can she have, you know, Graves' disease and a thyroid secreting extra hormones? And I'd say all those are possible. I agree with doing an iodine uptake test this week. I think that's a good idea. If she really has Graves, it would be, or, you know, overactive thyroid for whatever reason, not the medicines. It would show a increased uptake. If it's just over replacement, then it won't show anything. So I think the iodine scan is a reasonable uptake. I would also do a what was I going to say? Oh, there's two types of tests, uptake and a scan. I think you should do both. And more important is the scan. The scan tells us a picture that tells you where on the thyroid is overactive. So the uptake is just a number. So you want to do both. Maybe you meant that, but you want to do both the uptake and the scan.
I have a question.
Okay.
It's Kelly McCammon again. I just recently had the blood work done that you ordered for the TSH third generation, and came back at 4.8, which was flagged high. I will have an appointment about that. But
right.
My other numbers were normal. So in general, you know, what is the TSH third generation?
Well, the TSH third generation means it's a modern assay. It's just like, everybody does a third generation assay now, so it's sort of silly for them to write that. But in general, if you have a pituitary problem, you expect usually a low TSH. If you have a thyroid problem, you can have a high TSH, but it's usually in the accompanied by a positive TPO antibody. So I think we need to look at your numbers to see whether this high TSH is part of Hashimoto's and is a primary thyroid problem, or is it you know, something related? You can have a high TSH that doesn't work well in pituitary problems, bioinactive TSH. So it could be that. So we need to talk to see what's the next step and how to treat you from there. Maybe we repeat it. You know, in general, something's a little bit out of ordinary. Somebody with a pituitary problem shouldn't have such a high TSH. We probably want to repeat it and just make sure it's correct.
Sounds good. Thank you.
Okay. Other questions?
Oh, can I ask another question? Sorry.
Go ahead. Sure.
Yeah. So I'm having like my 3-4 month follow up with my neurosurgeon. From I mentioned before I had Cushing's. Now I have 25% of pituitary. What should I mention or ask during that follow up with him? I'm having an MRI earlier in the day.
Right. So I think the first thing is, are you properly hormonally replaced? Thyroid, testosterone, growth hormone, are all those optimized? In general, most patients with Cushing's can start tapering off their cortisol. 50 is way too much, and you want to try to get down and maybe get off of it soon. So I think you want to talk to your endocrinologist. Are you recovering? And as I said, cortisol is the most preserved hormone. So if you only have 25% of your pituitary, you usually have enough cortisol secreting cells. So it's rare for people to have cortisol deficiency, permanently after cure from Cushing's. I have a few patients that happens, but most patients, they can get off their cortisol.
I've been, I feel like I've been having where I needed it, where I had kind of where my adrenals were, like pain in my back in the morning, and I would take the cortisol, and I'd feel better, and I've been having that less and less, and as I've been having less of that, I've been, weaning down. But my appointment this week is actually with my neurosurgeon. What should I ask him?
So, I think just to make sure the tumor's gone, I think in general you need really to concentrate with your endocrinologist.
Okay.
Yeah.
Hey, Dr. Friedman?
Uh-huh.
Dr. Friedman, hey, this is Carol in Mississippi.
Hi,
Dr. Friedman, I have secondary hypothyroidism, and I started my growth hormone track today. My TSH is 0.016, and my T4 and T3 are both on the pretty high, they're both high, like they're off the charts. But I don't feel hyperthyroid at all. In fact, I'm really feeling better than I think that I have in a long time. But I think your recommendation was for me to lower the levothyroxine. I guess I'm just concerned that it's like now I'm feeling so good, even though my numbers are, so low and so high, that I'm going to have a shift in how I feel.
Yeah. So Carol's question is, sort of how do you balance numbers versus symptoms? And her free T4 and free T3 were high. They weren't high. I don't know, from what I remember, they were high. And my guess is she'll feel just as good when they're at the top range of normal as if they are over the range. Yet she won't have the potential problem for osteoporosis, other side effects of too much T4 and T3. So in general, I really try to work on symptoms and labs. But, when they're high, I would prefer them to be a little less high. The other question that Carol brings up is it's very important when you have a pituitary cause of your thyroid, your TSH is low, and when you treat it, it gets even lower. So in general, some doctors say this person's TSH is 0, she's on too much medicine. But if you have a pituitary problem, you're not on too much medicine. So, I think you have to sort of balance it out. But next question.
Thank you so much.
Sure, Carol. The next question from Katrina is, how do you test for low aldosterone? It's a blood test. In general, I usually get it most in the morning, and an aldosterone and a renin. I usually just do it sitting. I looked at standing and lying, and it didn't seem to matter that much versus just getting it sitting. So I would start with an aldosterone and renin level.
Dr. Friedman?
Uh-huh.
I'm interested in becoming a patient of yours. I emailed a little over a week ago. Is there a long wait to see you? I haven't heard anything yet.
No, there's a long wait for Lynn to respond and schedule you, but there shouldn't be that long a wait to see me. So hopefully we'll get you in pretty soon.
Great. Thank you so much.
Okay, sure. The next question from Katerina is also, she's had weight gain after several months of growth hormone and low cortisol. Why is that? Thyroids are normal. So, you have to really sort of evaluate everyone's labs. And if maybe some people with low cortisol, they just feel so lousy. They don't exercise, they don't get up, they eat lousy, and they actually, if you put them on cortisol, they'll feel better and they'll lose weight. You have to see what the growth hormone is. Other medicines, can affect weight. So you really need to be seen by, a top endocrinologist and make sure everything's optimized.
I also have a question about depression as a symptom of growth hormone. Are we depressed because we feel like crap all the time, or is it the actual hormonal deficiencies that cause a chemical depression?
I think it's a little of both. And many patients, they're feeling dead tired, they just have poor quality of life that aren't properly treated on their hormones. You ask them, are you sad and crying and blue? They say no, so they really don't have depression. They just have low quality of life and not optimized replacements. Other patients, they're crying away, they're sad, they're blue, and they need to be on antidepressant. And maybe the pituitary hormones seem to affect some of the brain hormones that are involved in depression. So, you know, it can go both ways. There is
oxytocin?
Right, such as oxytocin is a possibility, and some other things. There was a very interesting article that is on my website, I think, or I can send it to people who need it. It was a review article on what's called apathetic depression and pituitary. So patients with pituitary problem have this more apathetic depression, sort of low energy, blah. They're not that actively crying or sad, but they just feel sort of blah and apathetic. And these people respond better to stimulants than to like depressants like SSRIs.
Thank you.
Sabina asked about still having insomnia in spite of going on a higher dose of growth hormone. So in general, growth hormone does help someone sleep. And it allows you to go into like the deeper stages of sleep a lot of times, more the stage 3 and stage 4 sleep, but non-REM sleep. But there are other causes of insomnia, and we were evaluating this patient for Cushing's. I don't think she has it, but that would still be in the back of my mind if somebody has insomnia in spite of sort of proper hormones. And, you know, insomnia is a common condition, that it's not only hormonal and endocrine related. Okay, how about 2 more questions, and then we'll call it a night.
Dr. Friedman?
Uh-huh.
This is Janet Pingree again.
Hi, Janet.
And hi there. I've referred a patient to you who is coming for cortisol evaluation of thyroid after being on long-term prednisone, and I'm wondering about the cosentropin stim test, the ACTH test. And is it possible to get an order from you and have it done when he returns, or is it better to have it done there?
You know, either way is probably okay. You know, I sort of want to, sometimes I just get a cortisol level. You know, a lot of times, you know, the cortisol will give you the answer. You don't need the cosentropin test. If you have a real low cortisol level, you don't need it. If you have a real normal one, you don't need it. So it's only sort of in a gray area that people need the cosentropin test. So I'd like to sort of evaluate him, and then we'll sort of determine whether he needs it. We can either do it locally or back home. Okay. You know, the glucose test is sometimes hard to get. Everybody does the cosentropin test, so it's pretty easy to get that arranged at home.
Okay, thank you.
Dr. Friedman, hi. This is Jeff McCammon, Kelly McCammon's husband. I had a question regarding. Oh, you gotta be kidding me.
Yeah, we can hear you. Go ahead, Jeff.
You're there. Go ahead. Are you there?
Okay, I'm sorry. I was moving the iPad and I hit the button. Sorry. So, how can you tell if it's when you start moving into the hypothalamus, and is there a way to like tell if it's tertiary as opposed to like secondary, you know, hypopituitarism, or when you're having like low thyroid and things like that? Yeah. Is there a scan for the hypothalamus like you do for the pituitary?
Yeah. So that's a good question. I think that's a very hard thing to answer. I would say most patients have pituitary basis of their problems. You know, they had surgery, radiation, a tumor, all those would be based on a pituitary. Somebody could have a tumor in their hypothalamus. You could see it on a scan, like a craniopharyngioma. They could have sarcoid. They could have other infiltrative diseases. Some infections can affect the hypothalamus. So in general, you know, when they do the pituitary, they usually look at the hypothalamus, and if they see some, you know, some tumor or something there that's inappropriate, you know, then you could say it's hypothalamic. But I would say those cases are relatively rare, and most patients have pituitary, but it's certainly worth getting an MRI. Basically, your treatment is going to be the same for most diseases, most hormones, is, you know, replacing the hormones, whether it's pituitary or hypothalamic.
Okay.
Okay. Okay.
Thank you so much.
We'll call it a night. I'll try to get this posted on my website shortly, and we'll do the next one in a couple months.
Thank you very much.
Okay. Bye-bye.
Thank you.
Bye.
Thank you. you.